Good morning, everyone. I'm Puvasree from M4, and I will be presenting today's clinical presentation, Shingle, ready to mingle. Mr. S, a 76-year-old farmer from Chittoor, came with complaints of fever for 3 days, altered sensorium for 2 days, and seizure of 2 episodes. History of presenting illness: he was apparently normal 3 days before admission, and he developed fever which is low grade, intermittent, not associated with chills and rigor. There was associated right side chest, non-radiating, burning type of pain, not associated with breathless and palpitations. 2 days before admission, his relatives noted that he was drowsy, not able to recognize his family members, and had decreased verbal output. On 1 day before admission, he had abnormal jerky movements of all the four limbs with upward rolling of eyes, clenching of teeth, and associated urinary incontinence. He was taken to a nearby hospital where he had one more episode of seizure, and hence he was referred to CMC for further management. There was no history of contact with animal or dog bite, no history of recent travel, no history of drug addiction, no history of exposure to TB patients, no history of recent vaccination. Past histories was unremarkable. The differentials considered were acute meningoencephalitis, bacterial Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza, and Listeria, viral shrub encephalitis, herpes simplex, herpes zoster encephalitis, parasitic cerebral malaria. On examination in the ED, his respiratory rate was 30, pulse rate was 92 per minute, BP was 190, 100 mm of Hg, SpO2 was 100%, GCS was E2, V2, M4, and GBRS was 120. General examination, the patient was drowsy, disoriented to time, place, and person. There was no pallor ictus, cyanosis, clubbing, pupil edema, and lymphadenopathy. Systemic examination, S1, S2 was heard, there was no added murmurs, JBP was not elevated, normal vesicular blood sounds were heard, no added sounds was present. Abdomen soft and non-tender. CNS examination, neck stiffness was present, bilateral pupil was 2 mm reacting to light. So this was a local examination. There is a group clustered vesicles all over the right anterior chest involving the T5 dermatome. Investigations, the total count in differential counts were 9,000 with neutrophilic predominant. HB was normal. Platelet count was 265,000. Sodium and potassium was 125 and 5.6. Urea creatinine was 72 and 1.95. Serum electrolytes, HbA1c was 5.8. Troponin T was 20.2. CKMB is 4.8. LFT and PTINR was unremarkable. The CSF analysis, there was leukocytosis with lymphocytic predominance, and the RBCs was 50. CSF protein was 440, and expert TB was not detected, but PCR for multiple viruses, varicella zoster was positive. In his culture had no growth. So diagnosis acquired was acute meningoencephalitis, probable due to varicella zoster and systemic hypertension. So, a little into herpes zoster. Herpes zoster is a human herpes virus 3. In it, it get transmitted through respiratory route by inhalation of the vesicles which are present in the skin, and also to direct contact with the vesicles. Active vesicles are the ones which are known in active transmission. So usually it goes antegrade into the nervous system, and it stays in the latent period. During reactivation, it travels antegrade back and produces signs and symptoms. The clinical presentation usually involves confusion, headache, seizures, nausea, gait disturbances, and personality changes. The risk factors for reactivation of zoster, the most common is age. Age-related immunosenescence is the most common, and immunocompromised patients, transplant, autoimmune diseases, physical trauma, and comorbid conditions can also cause reactivation of the zoster. The comorbid conditions usually include chronic respiratory conditions, diabetes, any stress, then condition. This is an article published by our department studying 17 patients with the relationship of diabetes and the output of the varicella zoster. They highlighted that vaccination should be considered in patients with diabetes without immunity to varicella zoster, and those with diabetics should be aggressively treated first. And so, I would like to implement the use of vaccine. Is vaccine actually going to make a difference? So, the one that's available in our hospital is Valerix, which is rupees 2,100, and Mrs. S's IP bill was around 1,10,000. So we can also see the study which was done on 6,000 people with the mortality of varicella encephalitis is 5 to 10% in normal immunocompetent patient, and in immunocompromised it was 80%. So beforehand, vaccinating the people who are immunocompromised will actually be a cost-effective approach. And this is secondary attack rate of people who are unvaccinated was 71.5%, and vaccinated people were 15.1%. The vaccinated cases were half as contagious as unvaccinated people, and the vaccine is effective in controlling the disease in 78.9% of patients. There are no recent studies of differentiating the vaccine effectiveness, and we would like to do more research on further. Take-home messages: it is a highly contagious yet highly preventable disease. You have to watch out for signs and symptoms like the crusted vesicles we appreciated. Identify high-risk groups and vaccinate them, and watch for cluster of cases and notify if needed. So the reason why it was Ingle ready to mingle was it mingled with the CNS system and fast.
Thanks, Puvasree, for explaining why you called it what it is. Can you just show us your first slide again? The first two slides, sorry, I apologize, when you said the history. And next one was on where was the description of the skin lesions? No? You said burning type pain, and he had discussed it. And this was how long before the?
This was 3 days before.
3 days, right. We have, it's not unusual, but it's rare, but we have seen and made associations like this based on clinical examination also. Any questions from the group? I know there was some vaccination conversation also there. So is there anything to add to the clinical examination versus the vaccination recommendation?
Big topic.
Yeah, it's too much.
Poor efficacy. Number incidence is very low. So overall protection is only around 50%. So you cannot just casually discuss vaccination like that. What she means. Discuss that later.
We'll discuss the clinical implications, because I think that's what the clinical meeting is about. The vaccination area is a whole other topic, as Dr. Ramya mentioned. Go on, Amit.
Yeah. Not sure if such high CSF14 is common in
we did consider TB meningitis and we did started on empirical.
Teacher was a pathogenesis of CNS infections, and so he didn't say that you did not consider TB. Saying why is it happening?
As we discussed with the previous patients, I'm saying, sorry, previous students also, when anything sticks out, we always are a little worried that the patient will not come back with something else, or that's always a worry. So in a discussion for a summary like this, you may actually say, there's some things that we didn't exactly fit, but we are taking our best course for the safety and good faith. So some of those findings in the clinical meeting, even for others, when you have something that sticks out, it's good to stop and comment on it. It's real time. We all stand by a bed and wonder about how do we explain this or not. And then we took the next best course. You got culture growth. I mean, you had it on the PCR, etc. That's the general feedback. Any other questions or comments? Okay, thanks, Puvasree. So we've come to the end of this time's clinical meeting. I'd like to thank all the presenters and the units. Is some sorry? Oh, there's this question. So this time, I would like to kind of hand there is an award sitting here for the best presentation, but I'd like to give it to Dr. Lalam Koya in Makunda Hospital. It's pens. I don't know how we'll get them to you. We'll post it to you all. We do welcome everyone, but having said your pens, congratulations. Okay, yeah. So we do encourage more presentations from there, and we would also like the approach that you all have followed, those kind of indications to also be learned by our postgraduates, because at times in a tertiary to quaternary care, we find it, sometimes difficult to differentiate what should be done first, but that's our learning motto, that we focus on history and clinical examinations before we go on to, do the investigations, hopefully have a differential by then. Thank you so much for joining us, and congratulations. Nothing to take away from the others. I think we all are aiming to be the best versions of ourselves as clinicians, and it's a lifelong journey. I would say that even at this point in my life, I'm sure Ramya would agree that it's constantly a journey of history examination, getting your differences, and then doing the investigations. So thank you all for joining us. And next Saturday, I think is a clinic, is a PG clinic. So any final comments are allowed. We've shot up by 5 minutes. It's okay. But anything else that anybody would like to ask or give wisdom or clarify? I think the only thing is, Abhay, I'd like to congratulate you to stop. You stopped at a certain point and asked for discussion. I'd like everybody also, if that's okay, to stop at the end of your history and examination and ask what everybody thought. Then it's nice for a discussion, and that's a good way to do. So maybe that's something that we could suggest for everyone to present after you. So thank you all for coming. Have a good weekend, and thanks again to Medicine 5 for conducting.